This is Dr. Nala Perumal from Chennai. The problem of obesity has reached epidemic proportions, and the entire world is struggling with this problem. So, when it comes to managing obesity, we need to look at the root cause for obesity, which is an improper diet and lack of physical activity. So, this presentation is all about targeted dietary intervention for obesity, which I presented some time back in Madurai. ஸோ எந்த ப்ரெசன்டேஷன்னாலும் திருவள்ளுவரோட வாக்கு இல்லாமல் ஆரம்பிக்க முடியாது. அந்த அளவுக்கு அவரோட நாலேஜ் அது அமேசிங். நீங்கள் யோசிச்சு பார்த்தீங்கன்னா திஸ் திருக்குறள் எண் நம்பர் எண் 947. தீயளவின்றி தெரியான் பெரிதுண்ணின் நோயளவின்றி படும். இதோட தேவநேய பாவாணர் உரை என்னன்னா, ஒருவன் தன் உடற்கூற்றையும் அதற்கேற்ற உணவையும் அதை உண்ணும் காலத்தையும் அறியாது தான் விரும்பிய உணவுகளை எல்லாம் விரும்பிய பொழுதெல்லாம் தன் பசியளவுக்கு அல்லது செரிமான ஆற்றலுக்கு மேற்பட்டு பேரளவாக உண்பானாயின் அவனிடத்து பல்வகை நோயும் தோன்றி வளரும். I don't think anybody else can explain about the current scenario better than this குறள். தீயளவின்றி தெரியான் பெரிதுண்ணின் நோயளவின்றி படும். So obesity is a chronic, heterogeneous, neuroendocrine, progressive and or relapsing disease impacted by the obesogenic environment and genetic susceptibility factors, resulting in excess or abnormally distributed adiposity, which impairs overall health. This is the current definition for obesity. There are many environmental drivers for obesity. So among them, the important ones are ultra-processed, high-calorific food access. The presentation will be revolving around this particular aspect today. Sedentary technology-driven lifestyle. We all have gadgets in our hand. So we don't walk to do anything now. We can finish our work within the space of the room with the mobile gadget in our hand. Stress and sleep duration, that also is getting reduced, even for children because of their academic stress. And urbanization and unsafe physical spaces. Even if you ask your patients to walk, there is no safe space for them to walk. Dog menace, chain theft, all that is there. And endocrine disrupting chemicals that has influenced our food chain can create havoc. Digital marketing and food delivery ecosystems like Swiggy and Zomato, all those apps. Before even you think, okay, I don't want this ice cream today, you would have ordered it and it will reach your doorstep in the next 10-15 minutes. So this is another big problem facing the youngsters. And early life exposures and weight promoting medications, which our moms, the pregnant mothers, are getting exposed to, and socio-cultural norms and socio-economic barriers. So these are all the environmental drivers. This is an important picture, which is called obesity system map. See, obesity is a complex disorder. You can see the complexity, how each factor is interacting with each other. So you can see on the left is the food systems. On the right is a physical activity, and there are a lot of interactions. So many factors are interacting. For example, media, social level, psychological level, economics of the food system, activity, infrastructure, developmental, biological, medical. There are so many domains which affect the problem of obesity. So the current presentation is all about the obesogenic environment. So today's presentation is about targeted intervention for obesity. இந்த குறள் ஆரம்பிக்கலாம். தீயளவின்றி தெரியான் பெரிதுண்ணி நோயளவின்றி படும். ஒருவன் தன் உடற்கூற்றையும் அதற்கேற்ற உணவையும் அதை உண்ணும் காலத்தையும் அறியாது தான் விரும்பிய உணவுகளை எல்லாம் விரும்பிய பொழுதெல்லாம் தன் பசியளவுக்கு அல்லது செரிமான அளவுக்கு ஆற்றலுக்கு மேற்பட்டு பேரளவாக உண்பானாயின் அவனிடத்து பல்வகை நோயும் தோன்றி வளரும். இது தேவநேய பாவாணர் உரை. Nobody can explain better than this about the current problem of obesity. The definition for obesity is it's a chronic, heterogeneous, neuroendocrine, progressive and or relapsing disease impacted by the obesogenic environment and genetic susceptibility factors, resulting in excess or abnormally distributed adiposity, which impairs overall health. There are many key obesogenic environmental drivers, which includes ultra-processed high calorific food access. We are surrounded by hyper-palatable food, sedentary technology-driven lifestyle, which includes our mobile phone, all gadgets, stress and sleep disruption. Even for children, they are under academic stress and then they don't sleep properly. Urbanization and unsafe physical spaces, endocrine disrupting chemicals which have entered our food chain, digital marketing and food delivery ecosystems like Zomato, Swiggy, early life exposures, especially for mothers when they start eating high calorific food during their pregnancy, the baby also gets programmed to that kind of food. And weight promoting medications used in pregnancy, as well as socio-cultural norms and socioeconomic barriers. These are the key obesogenic environmental drivers. And this obesity system map, which has many domains. The main domains are food and physical activity domains, but there are other domains like economics, psychological, social, media, infrastructure, developmental, biological, and medical. So this is a very complex disorder. That's why people struggle with it. And today's presentation is going to focus on the obesogenic environment, especially the ultra-processed and high calorific food access. In subsequent presentations later this year or next year, we'll be discussing the other factors. So this is the global trend in obesity between 1975 to 2016 in the world. On the left, you can see the map for 1975. These are all the small dots and small circles are the countries. The number of people living with obesity, if the numbers are high, the bubble will be little bigger. Okay, so you can see the transformation between 1975 to 2016, where the bubbles have become bigger and blown out for many countries. So obviously, the number of people living with obesity has gone up. You can see India there still growing, and US at this point of time is the biggest bubble, the blue one, and China, the orange one, and so on. So definitely, there is no doubt that the epidemic of obesity is growing and it is threatening our economics. And this has not happened over time. See, these are all hunter-gatherers. So they lived thousands of years ago. They were very physically active. They were eating only the natural stuff and meat, and they were physically very agile. Not that we have transported to a modern environment fast. What happened in between? See, you can see obesity saw an uptick in the early 80s only. In the x-axis in this graph, you can see starting from 1955 to 2000, year 2000. Around 1975 to 80, the obesity levels in men and women, the different colored lines are different age groups of women and men, which is depicted on top. So you can see all the age groups, both men and women, the incidence of obesity and overweight started going up around the mid 80s. Okay, so what happened around that period? So it was okay before that. And this is data published from Australia between 1901 to 2003. This is 102 years data, okay, of children. So you can see the topic, descriptive epidemiology of childhood overweight and obesity in Australia between 1901 to 2003. Again, you can clearly see from 1900 to 1970, it was okay. And after 1980, there is a huge uptick there. The number of children living with overweight or obesity has gone up. So again, around the same time, for children also the same problem occurred. So this is before going into the details of that graph. So you can see another factor influencing our sugar intake. See effects of global warming on added sugar consumption in US. This is the data from US. On the left, you can see the temperature in the x-axis from 0 degree to 34 degrees. And on the y-axis, you can see the changes in added sugar consumption. So you can see slowly as the temperature became warmer and warmer, as the earth got warmer, the sugar intake also was going up. And they analyzed what kind of beverages or foodstuffs are consumed by these people as the temperature got warmer. So you can see again on the right side, while the bakery stuff went down, the pastries and other things slightly went high, whereas it was mainly driven by sugar added beverages. So frozen desserts, a minor increase happened with it, increase in global warming, but sugar added beverages like Coke, Pepsi, the consumption grew enormously. So people were thirsty and they started drinking these kind of beverages, fruit juices, instead of water. Okay, so increased consumption of sugar in this form. And if suppose, assuming that this global warming is going to continue unabated, if nobody is reducing the carbon footprint of what we are making today, the number of aircrafts continue to rise, a number of polluting vehicles continue to rise, number of air conditioners which we use continue to rise without any respite, then what will happen in 2090? This is the worst prediction. The prediction is called as SSPS 8.5 scenario. They have these are all various scenarios they have predicted. The worst case scenario is predicted by this particular number SSPS 8.5, wherein they have predicted that the Earth will be hotter by 5 degrees more than what we are today. And what will happen if the same level of sugar consumption is going to happen? Then you can see the added sugar consumption further going up by 2090. So this is going to trigger further epidemic of obesity and other things. So what we have done essentially is it's not that we have transported these hunter-gatherers suddenly into a built environment selling Coke and Pepsi overnight, but it has happened over time. So what really happened in the mid-80s, which saw an uptick of obesity, there was a transition from naturally grown foodstuff to ultra-processed food. You can see the transition from the left to the right to ultra-processed food. This was probably the main reason for the obesity epidemic. And literally, we took the risks and shot the apple. So we just killed the natural foodstuffs and started consuming more of ultra-processed food. So this is an important person known as Carlos Augusto Monteiro. He's a scientist from Brazil. Brazil is one of the countries which struggle with obesity epidemic, and he analyzed why this is happening in our country. So when he did a lot of research, he found that ultra-processed food intake was very high in Brazil, and he guessed that probably because of that it is going up, the obesity epidemic. So he was the one who coined the term ultra-processed food, UPF, in 2009. He was the one who coined the term. So what is ultra-processed food? They are manufactured products made from substances extracted from foods. They are not real foods, extracted from foods like oil, fat, sugar, starch, and proteins, or synthesized from hydrogenated fats and modified starch. Typically ready to eat or require minimal preparation. You just buy it in a small plastic cover, cut it open, and then eat. That's it. No preparation is required. And it contains a lot of additives like colors, flavors, and preservatives, which are all chemicals. They affect to our health, which we do not know, and often contain higher levels of sugar, fat, salt, while being low in nutrients like fiber, vitamins. So these stuff are always high in sugar, fat, and salt, which makes us to crave for more. And they are naturally have less important contents like fiber and vitamins. And more importantly, ultra-processed food are engineered to encourage overconsumption and are associated with higher calorie intake. We end up eating more. So definitely, we need a paradigm shift in how we view and consume our food today. And you can see this is a no classification. This is a spectrum of processing of food. So now our classification is about the processing which happens to our food. On the left, you can see group 1, unprocessed or minimally processed food. So like, for example, fresh, dry or frozen vegetables, fruits, grains, legumes, meat, fish, eggs, nuts and seeds. These are all the things which we normally eat. So maybe minimal processing, like you want to remove the inedible or unwanted part. For example, you cultivate the rice and you cut the rice paddy. You have to remove the plant part of it. No, that is minimal processing. Does not add any substance to the original food. You are not adding anything to it as a preservative or anything. So minimal processing. The group 2, processed culinary ingredients like plant oils, like you derive this from something else like olive oil, coconut oil. You crush the coconut and then get that oil, like that, animal fats and so on. Group 3 is processed food, canned, pickled vegetables, meat, fish, fruit, cheese, salted meats and so on. Group 4 is ultra processed foods, sugar sweetened beverages, sweet or savory packaged snacks, reconstituted meat products, pre-prepared frozen dishes, canned or instant soups, chicken nuggets, ice creams, and so on. So these are the formulations made from a series of processes, including extraction and chemical modification, includes very little intact group 1 foods. So we don't have much of the group 1 foods here. These are all highly processed foodstuff with lot of chemicals. So this is the increasing level of processing which happens from group 1 to group 4, and now we eat more of group 4. There is a data which suggests that almost 65% of the foodstuff in advanced nations are from ultra processed food only. And ultra processed food is everywhere, every nook and corner. If you see, this is a locality, say Adayar region. Every nook and corner, you have a fast food outlet and outlet selling all these ultra processed stuff. And just to let you know about this ultra processed thing, on the left, you can see the image of this particular sandwich like thing, which looks very organic, right? You can see the bread slices there and you can see the natural stuff, a salad. So this is called smoky carrot or falafel. This is marketed by Pret. So Pret is a big food company, just like McDonald's from UK. Pret is a very popular food company from UK. They have collaborated with Reliance Industries to bring their outlets to India. Already they have opened their outlets in Mumbai and Hyderabad. Soon it will they will open their outlets in Chennai and other cities too. So this smoky carrot falafel, which I downloaded from their website, is sweet potato falafel with smoky carrot ribbons. You can see the carrot there. Gherkins, pickled cabbage and carrot, and a layer of stricha sauce finished with handful of rocket. So this is how they have described this sandwich. And if you look at the content, you can see so many coloring agents, chemicals. For example, monodiacetyl tartaric acid esters of mono and diglycerides of fatty acid, mono and diglycerides of fatty acids, ascorbic acid, vinegar, flavoring agent, coloring agents, modified starch, xanthan gum, and so on. So this is a processed food. Obviously, it looks very, very organic. Looks like we can get it for our children. But imagine how many processing agents have gone into this. So higher consumption of ultra processed food is associated with weight gain, with gain in BMI and higher risks of overweight and obesity. This is a very important study done in France. It's called Etude Nutrinet Santé study. So what they did, it was a prospective study. They enrolled young adults, say adults between 25 to 30 years into this study. There are a huge number, 1,10,260 young healthy adults were enrolled, and they were given questionnaires like what is your monthly purchase, groceries, what do you eat, and there's a detailed questionnaire about their food intake, their purchases, which has happened over the last quarter. So every quarter they administered the questionnaire, and at the end of 9 years, they assessed, they divided them into 4 groups. The group, the quartile 1, which has got the lowest ultra processed food intake, that is the blue line, and the top line is the quartile 4, which consumed the maximum level of ultra processed food. So you can see what happened in the x-axis, the years of follow-up, up to 9 years of follow-up. You can see gradually the weight of these adults went high, and it was the highest for the quartile which consumed the maximum amount of ultra processed food. And the starting BMI was around 23, and they ended up at nearly 24.7. Okay, so they have gained so much of weight in 8-9 years of follow-up time. So ultra processed food intake definitely makes you obese. But where is the proof? This is only an epidemiological data. Do we have proof for that? So this is an important study which suggests that ultra processed food consumption is currently driving the obesity epidemic. This paper is titled "Ultra Processed Diets Cause Excess Calorie Intake and Weight Gain," an inpatient randomized control trial of ad libitum food intake. Ad libitum means they are allowed to eat whatever they want. That is called ad libitum. And this is not a pharma or food industry sponsored trial. So this was funded by the US government. You can see the investigators belong to 4 national centers of excellence from US and Singapore. National Institute of Diabetes and Digestive Kidney Diseases, Bethesda, USA, National Institute of Health and Health Clinical Center, Bethesda, National Institute of Nursing Research, Bethesda, and Singapore Institute for Clinical Sciences, Singapore. So all funded with the government money and NIH, NIDDK funded study. What they did was they wanted to investigate the causal role of ultra processed food on energy intake and body weight change. 20 healthy adults were admitted for 28 days. So they were inside the hospital. Okay. They were admitted and they received ultra processed and unprocessed diets for 14 days each. Within those 28 days, first 14 days they received ultra processed diets, and the next 14 days they received the unprocessed diet. The other group, again, the vice versa. Okay. So these adults were made to do stationary cycling for about 60 minutes every day, which is equivalent to our walking and doing daily course. We go to office, come back, all that. No, so they mimicked that kind of physical activity within the hospital with stationary cycling. Baseline anthropometrics of the study subjects, you can see the age, the median age is around 31 for all of them. Males and females were equally distributed. There is no gender disparity. It's only a number of participants were small, 20 only, but it was well-designed trial. I'll show you how. So 20 of them, 10 males, 10 females, and all of them had a BMI, which was almost equal. And you can see the body weight was around 78 kilograms. Body fat, fat mass, everything was measured. Resting energy expenditure was also measured. The average BMI was around 27 kilograms per meter square. And this is a trial design. On top, you can see the 20 people were randomized into 2 groups. One group received 2 weeks inpatient ultra processed diet, and the next 2 weeks they were changed over to unprocessed diet. The other group received unprocessed diet first for 14 days, and the next 14 days they received ultra processed diet. And during their stay in the hospital, the total energy expenditure for 14 days was assessed with a doubly labeled water method, DLW method. You can see the equipment there. It is a cumbersome experiment, but they did everything perfectly. Total energy expenditure for 14 days was calculated. And you can see the DEXA there to assess the fat mass. And MRI and MR spectroscopy was done again to assess the fat mass. And then 24-hour chamber experiment was done to know the 24-hour energy experiment. All of them underwent a fasting sample. They gave a fasting sample for various blood tests, and oral glucose tolerance test also done. And their diets were matched for presented calories, carb, fat, protein, fiber, and nutrients. Nothing changed except one group received ultra processed, but the content of the carb, fat, protein, fiber, everything was the same. The other group received processed diet. Okay, unprocessed diet. So you can see the 3 meals there, 3 daily meals, breakfast, lunch, and dinner. So the 3 daily meal, the energy was around 3,900 calories for ultra processed and 3,800 calories for unprocessed diet. Carb content is 49, 46, almost all are similar. For snack, they were provided with snacks also. Again, everything was similar. If you combine both daily meals and snacks, because remember, this is an ad libitum intake. So they will be given a lot in their room. Whatever they want to eat, they can eat. Leave it, or if they don't want, they can leave it like that. So they were provided with 5,435 calories of daily meals and snack of ultra processed, or 5,436 calories of unprocessed meals or snacks. Okay, I hope I'm clear here. And I'll show you what they were actually provided. These are the photographs downloaded from their website. Actual meals they were eating. These are the daily snacks they were provided. Unprocessed, on the left you can see unprocessed, which included oranges, apples, nuts, and so on. So you can see raisins, raw almonds, chopped walnuts, and all. And on the right you can see the processed group received these kind of snacks. So which include baked potato chips, which is Lay's chips, dry roasted peanuts, cheese and peanut butter, sandwich crackers, goldfish crackers, and applesauce. So all these were ultra processed, but the calories will be the similar. And these are the sample breakfast. We have all the 14 days breakfast captured in the website, but I downloaded only 2 days breakfast for you to just analyze. So on the left, you can see unprocessed. You can see on the top, unprocessed food is in green, and processed food, industrially processed food, is black. So you can see in unprocessed, you can see an omelette there, and vegetables, fruits, milk, and all. And on the right, you can see the processed ones. Okay. The lunch is also on the left, on the left unprocessed, on the right ultra processed. Again, dinner unprocessed versus ultra processed. So now they did blood test at the baseline and at the end of it. So you can see how extensively they were analyzing the data. So you can see all the gut hormones were measured at the baseline and at the end of the trial. You can see, just I'll read out few of the gut hormones: leptin, active ghrelin, PYY, FGF21, adiponectin, resistin, active GLP1, total GIP, active GIP, glucagon, so insulin, C-peptide. So everything was measured. Okay, you cannot imagine doing a test like this for both the groups. And these are the energy expenditure experiments, 24 hours as well as total energy for 14 days, the data. And this is the result. You can see ad libitum intake. That is, those who were provided with ultra processed food, they were eating more because it was very inviting. Ad libitum intake was 500 kilocalories per day more on the ultra processed than the unprocessed diet. You can see on the left, the ultra processed is the blue one. You can see the calorie intake was around 3,200 kilocalories, and whereas it was around 2,400 kilocalories for unprocessed diet. And they looked at whether the carb content was high. Yes, in the ultra processed food, because they were consuming more, the carb content was slightly higher. And again, they assessed which meal they ate a lot, whether it is for breakfast, lunch, and dinner. Everywhere ultra processed intake was higher, and they looked at what grams of food they could consume per minute, how fast they finished, because they were provided with a meal in their room, and then once they finished, they will take out the plate. Okay, so how fast they could finish it, whatever they wanted to eat. So ultra processed food consumption was faster because you don't even need to chew because it's all processed, right? So you can see number of grams compared to the unprocessed was higher, and the kilocalories of food consumed was also higher. And what happened after 14 days? The ultra processed diet led to an increased body weight over time. So the unprocessed group lost 1 kilogram, whereas the ultra processed group gained 1 kilogram within those 14 days. That means there was a 2 kilogram difference between the groups. Okay. So you can imagine if within 14 days, a 2 kilogram difference can happen between the natural food eaters and ultra processed food eaters. If for a lifetime, starting from childhood, we are going to eat this kind of food, uh, uh, how can we prevent obesity then? Okay. And what about the body fat mass? Fat mass also increased over time with ultra processed diet and decreased with unprocessed diet. You can see they have actually lost about half a kg of fat mass in the ultra unprocessed food stuff, whereas for ultra processed, they have gained half kg of fat mass. The gain was half kg of fat mass within 2 weeks' time. Okay. So obviously in the brain, there are two centers which control our eating behavior. So homeostatic hunger is eating for calories. Okay. So when you're hungry, because you have not eaten for long, you're going to eat something because you need to provide for your metabolic requirements. We have to sustain our life. For that, you are eating, that is homeostatic. Whereas hedonic hunger is even after finishing the meal, we want a dessert. No, we still find space within our stomach to get it in. So after a full meal, you still want a dessert. That is called hedonic hunger or eating just for pleasure. So there is always a tug of war between the homeostatic eating behavior and hedonic eating behavior, and hedonic eating behavior always wins because it's very difficult to reduce the craving. So the food industry is processed food industry is an industry of engineered eating. They process it, add sugar, salt, and fat, everything in right proportions, so that it makes us to crave for more. You are not going to stop with one scoop of ice cream. You want another scoop like that. So the craving goes on. So it all is a vicious cycle. I'm not going to go through this picture. You can see how the vicious cycle is being propagated by the ultra processed food industry. Naturally, these are the brain mechanisms, very complex mechanisms. You can see some of the hormones are there to inform the brain that the stomach is full enough, whereas some of the hormones inform the brain that we want more. No, so there's a gut brain connection, and in the brain, in the prefrontal cortex, there is a problem of liking. You want it, you want, and you like it. So it is like an anticipation of food reward. No, food is considered as a reward, and it increases for overconsumption. So these are all complex mechanisms within the brain which make us to eat more and more. So food addiction is like new smoking. So you can see on the left top, we are chained to delicious food stuff now. And world is currently saturated with ultra processed food. They are highly palatable and they are very pleasurable because of the taste, and we derive a lot of pleasure from eating them. And there is behavioral, biological, and social rewards of eating, and it perpetuates overconsumption. We keep eating it. It is called hedonic. So hedonic eating is the problem what all our youngsters face today. In olden times, I'm taking a parallel to smoking. The smoking industry was a very greedy industry. Okay, they did a lot of unethical advertisements. You can see there were a lot actual advertisements used in those times to promote smoking. You can see they have used a pregnant mother, no, smoking a cigarette, claiming that it is a smooth taste, the smoke taste, which the expectant mothers crave for. And here on the right, if they have used a small infant, just one question, mom, can you afford not to smoke Marlboro? So you can see how greedy they could become. And obviously, the food industry has become such an industry. But then we have controlled the tobacco so much now. Success story again, even though smoking, but the numbers have dwindled to a very small number now because of these public health policies that reduce smoking rates. So we have removed all the hoardings, billboards, advertising cigarettes. We have changed the package design. Now, as doctors, all the cigarette boxes hold pictures of cancer victims, no, dreadful pictures of oral cancer, and we are taxing the hell out of it. Any government which comes in the center, any budget they make, in every budget you can see the first thing they do is to hike the price of the or tax for the cigarettes. It is correct only because you have to tax the hell out of it, make it more expensive, make it socially unacceptable also. So suppose for 10 people are sitting in a room, one person wants to smoke. In the olden days, they just take the cigarette packet and then start smoking. It was socially acceptable. Now they feel little bad. They go out of the room and smoke. And I understand you, all of you accept with this statement. And then restrict where you can smoke. Now in the airport, if you visit, there will be a small cubicle in the entire airport. That's where you can smoke. You cannot smoke everywhere, right? Restrict the place. Educating everyone about the effects on your health, and then educate the smokers about the effects on your loved ones around you. Suppose I'm a pregnancy diabetes expert. I always tell husbands, don't smoke because that is going to affect your unborn child because your wife is pregnant. So you are smoking because she becomes a passive smoker. It's going to affect the unborn child. So why should you give that risk to your child? So they understand. So now you draw the parallel to the obesogenic environment. Okay. So cigarette smoking versus obesogenic environment. There is a big elephant in the room. We are missing it out. So we try to fix everything with a drug, right? So, but the same drivers are operating, same ultra processed food, same level of physical inactivity, same level of stress, everything is there. Unless we act upon this, the palatable, addictive, fast acting carbs and processed food, somehow we want to reduce the consumption of these stuff by the population, we are not going to address the big problem of the elephant of obesity. So what is targeted nutrition for obesity management? When you go to a dietitian, generally they give a generic diet advice. Okay. Majority of the times they give a printed sheet. It's like one size fits all approach. You take 2 idlis, 3 idlis, or 2 dosa, like that. General healthy eating advice. Generally they do a good job, but then it's a general advice, right? Cut down your trans fat, cut down this, eat more fruits, like that, and ignores differences in eating behavior because it's not going to take into account what they prefer to eat or what is the cooking pattern in the home. So there are so many things which we need to factor in. Whereas targeted nutrition is which considers hyper palatable food environment, where they live, what kind of food outlets are close to their environment, how they make use of them, and focuses on appetite mechanisms and satiety, aims to reduce cravings and overeating, as well as it focuses on cardiometabolic goals, what we want to achieve, whether we want to reduce the visceral fat, whether we want to reduce the weight, reduce the burden on the aching knee joint, and so on. So targeted nutrition is a dietary approach tailored to an individual's unique needs, characteristics, and health status. So how do we do that? Initial assessment, which include weight history. Always start with their own birth weight. What was your birth weight when you were born? So if the person was born either underweight or overweight, then obviously they have a higher tendency to put on weight. Genetics, whether in the family member, they have family members with obesity, and pregnancy, how the mom was nourished, and medication and stress. And then a patient and family medical history, previous diets and weight loss attempts, how many times they tried to lose their weight, whether they followed keto diet, paleo diet, intermittent fasting, and so on, current medications, supplements, vitamins, and diet restrictions. Do they have any problems of allergies, intolerances, preferences, cultural considerations, and so on? And we have to always do a 24-hour diet recall. Who cooks at home? Who shops for grocery? Because that the purchase which what they make is also important. And focus on meals, snacks, beverage intake, and the timing of intake. Everything need to be assessed. Assessed for skipping on meals, distracted eating behavior, eating quickly, late night eating, ignoring hunger cues. All you need to ask. Then work schedule, sleep schedule, exercise regimen and timing, both present in the past, as well as you have to calculate the body mass index, waist circumference, and body composition analysis. So these are the minimal evaluation which you have to do when someone comes with adiposity-based chronic disease. The new terminology for obesity now is adiposity-based chronic disease, or ABCD, because when you write the diagnosis obesity, some people don't like the term obesity. So you can always mention that they've got ABCD. So initial evaluation includes medical weight history, physical exam, social history, laboratories, general health analysis. Then family history, you have to review a lot of systems, whether they got shortness of breath, orthopnea, dyspnea, chest pain, palpitation, so on. And then directed follow-up testing if required, for example, GTT, ApoB, chest X-ray, liver elastography, and so on. And this is a body composition analysis. I am showing you two cases here. So this is a normal weight person. You look at the BMI, the red circled area. There's a BMI is 18.9. So lean, normal weight person. You can see the visceral fat is not much. Whereas this is an obese person, the weight is 119 kilograms, body fat is 49 kilograms. When he weighs 119 kilograms and the weight of the fat mass is 49 kilogram, abdominal circumference is 129.6, nearly 130. Whereas for men, it should be less than 90. It is 130 for him. And you can see the visceral fat down below. It was too high. Okay. So this is the body composition analysis. When they come back, say after some weight loss attempt or your treatment, say 6 months later when you do, you get the data like this, body composition change. It will be printed underneath. So you previous as well as present. Then you will know whether the person is losing the weight, whether the fat mass has gone down, whether muscle mass is preserved. All that can be analyzed. This is body composition analysis by bioimpedance technology. The other technologies with which you can assess the body composition is DEXA scan as well as MRI scan, but they are very expensive. And we always start with behavioral or lifestyle therapy for people with obesity. So which includes nutrition, sleep hygiene, physical activity, as well as behavioral therapy. Among the four domains, the nutrition is what is the focus today. So obviously, the focus need to be on reduced calorie diet while maintaining the diet quality. So they can adopt a healthful meal pattern like Mediterranean diet, prioritize minimally processed nutrient-dense food, limit energy-dense foods and beverages, and ensure adequate nutrient intake of protein, fiber, iron, calcium, and other micronutrients. Because when they start losing weight, they are going to lose all this. So individualized energy plans may include macronutrient-based strategies, meal replacement, strategic fasting, or personalized calorific targets. Before going to that, mindful eating is what is more important. They have to notice the food. So mindful eating is when you have a plate of food in front, don't start eating it immediately. First, observe the plate for some time. Notice, observe, and then feel. It may be emanating some fragrant smell, smell of the food, and look at the visual image of the food. Then slowly you start tasting it. Use a small spoon to take it, taste, and take your time. Enjoy your meal. So this is called mindful eating. When you do that, start doing that, you will be eating less over a period. And this is to impress upon you how important it is to advise a reduced energy diet and increased physical activity, even if you are going to prescribe either semaglutide or tirzepatide to your patients for obesity management. For example, this is approval for semaglutide, approval slide. You can see semaglutide got approved 2.4 milligram as an adjunct to a reduced energy diet and increased physical activity, and is suitable for adults as early as a BMI of more than 27 kilogram per meter square if they have some comorbid conditions. If they don't have any comorbid conditions like diabetes, dyslipidemia, OSA, and so on, then their BMI should be more than 30 per kilogram per meter square for them to get prescribed with either semaglutide or tirzepatide. But remember, semaglutide or tirzepatide is an adjunct to reduced energy diet and activity. Not that reduced energy diet and physical activity is an adjunct to the drug. Okay, it's the other way around. The approval is like that. So all the trials which were done to get approval for semaglutide and tirzepatide, all the trial subjects, whether they were in the placebo group or the intervention group, they were advised to reduce their daily energy intake by 500 kilocalories per day. This is what you have to advise all your obese patients to start with. 500 kilocalorie per day reduction must be done. The personalized nutrition plan can align with weight and health goals. There are many meal plans. So with variant nutrient composition and reduced calorie format. So for example, Mediterranean diet, Nordic diet, DASH diet, time restricted eating, calorie restricted diet, vegetarian diet, partial meal diet, portfolio diet, and low GI diet. Any diet can be followed by the patient, provided they can follow it for a longer time. And if they are comfortable with that and they like it. But we have to look at the micronutrients and macronutrients, and we have to replenish whatever they are losing. So any diet they are using should enable long-term adherence. Prioritization of nutrient-dense carbs, lean protein, multivitamin supplementation during active weight loss phase is very, very important. When they start losing weight, they are going to lose their muscle mass and they are going to become deficient in nutrients, which we need to supply. And higher protein intake to maintain the lean body mass is very, very important. Impress upon them that they have to increase their protein intake. When we talk like this, they will not understand. You take lean protein. You have to take a lot of nutrient-dense carb. How will they understand? So this is a carbohydrate choice continuum. On the left, you can see the whole grains, no? The rice, wheat, all whole grains, unpolished. Whereas on the right, you can see full of processed stuff with the same ingredients. So you can see crackers, white bread, cola, fries, pastries, and so on. So eat less of these and eat more of the left-hand side whole grain things. So another simple thing which you can advise them, if it is through a machine, don't eat. For example, noodles, 2-minute noodle. It is coming through a machine processing. It is through a machine, don't eat that. So whole grain contains all three parts of the grain, like bran, endosperm, as well as germ. Refined grains are processed to remove the bran and germ along with many of the nutrients. So on the right, you can see the whole grain, the brown rice. 1 cup of cooked brown rice will provide 380 calories, whereas same 1 bowl of refined grains, white rice will provide 310, 30 calories extra, and 1 gram protein less and 1.5 grams fiber less. 70, it's more of carb and 0 iron and very low in magnesium. So you are removing a lot of nutrients, increasing the carb content and increasing the calorie content by refining the grains. It's very, very important to understand. And when it comes to lean meat versus fatty meat, on the left, you can see on top left, you can see 100-gram pork belly with a lot of fat there, fat streaks. That provides 349 kilocalorie. Whereas if you buy 100 grams, same 100-gram pork tenderloin, it's about 150 calories only. On the right, you can see 100 grams chicken drumsticks, 146 kilocalories, whereas 100 grams chicken breast with less fat, 118 kilocalories. And 100 grams of lamb chops, 203 kilocalories, whereas 100 grams lamb tenderloin is only 103 kilocalories, almost half. And 100 grams sauri fish, 314 calories, whereas 100 grams cod, it is only 88 calories. So you have to choose your meat and fish. And for vegetarians, you can tell them to have more beans, lentils, peas, and dal. Dal is nothing but broken pulse. And you can see the various dal varieties depicted here. All these are good for improving the protein intake for vegetarians, strict vegetarians. And again, you can see the nuts and fruits here. They are all good. They can be promoted as snacks whenever they feel hungry. Because remember, we are treating obese person. We are not treating a diabetic person here. So obese persons can take fruits, no problem. So they can, instead of having some ice cream or sandwich, a burger, when they want to eat something, they can have these things, which is going to be health. Which is going to improve the health. And hydration is very, very important. So water intake, as well as they can go for thin soups, as well as cucumbers, those kind of things. And then this is a simple slide where you can follow a meal plan to maximize the benefits while on GIP drugs. So, for example, someone who is on GLP-1 receptor analogs, that is semaglutide, or GLP-GIP co-agonist like tirzepatide, when they are on these drugs, we have to tell them to follow the meal plan. Meal plan is nothing but an acronym. M stands for maintain muscle. They have to increase the protein content. E stands for energize and balance. They have to take snack and slow digesting food to provide energy in between meals. And A stands for avoid GLP side effects like constipation, nausea, and heartburn. By avoiding fried stuff, by increasing fiber, by avoiding spicy stuff, and so on. And L stands for liquid for hydration needs, and P stands for physical activity while taking GLP-1, because they have to maintain the muscle mass. Any rapid weight loss, they are going to lose part of their muscle, so they have to do strength training. So we have to integrate nutrition and physical activity whenever your patients are on GLP-1 or dual receptor agonist therapy. And a final word about people who have undergone bariatric surgery. So obviously, if they have undergone major surgeries like mini gastric bypass or Roux-en-Y bypass surgery, they are going to lose a lot of nutrients by the way of poor absorption. So it all depends on where they have removed, which part of the GI tract they have removed. If it is part of stomach, they are going to lose on water, copper, iodine, fluoride, intrinsic factor, and so on. So if it is duodenum, jejunum, ileum, for which procedure they have undergone, you have to look at the possible nutrient deficiencies and supplement that. And finally, obesity is heterogeneous. Nutrition intervention should be individualized. Limiting consumption of ultra-processed food may be an effective strategy in the prevention and treatment of obesity. The choice of eating pattern should not be a short-lived experiment. It should support best health and can be maintained over time. Targeted nutrition is essential as an independent intervention, and anti-obesity drug therapy is an adjunct to it. Never forget nutrition and physical activity. Focus mainly on achieving good health outcomes rather than the weight. It's not about the number of kilograms lost. It's about the number of kilograms of fat lost in the central region, which is going to reduce the insulin resistance and improve the cardiovascular outcome. Practical implementation requires resources like dietitians, food data monitoring, technology like CGM, which remains a significant limitation for most of our patients. So, திருக்குறள் ஆரம்பிச்சோம், திருக்குறளே முடிக்கலாம். அதிகாரம் 95, மருந்து, குறள் நம்பர் 945. மாறுபாடு இல்லாத உண்டி மருத்துண்ணின் ஊறுபாடு இல்லை உயிர்க்கு. இதோட மீனிங் உடலுக்கு ஒத்து வரக்கூடிய உணவை கூட அதிகமாகும் போது மறுத்து அளவுடன் உண்டால் உயிர் வாழ்வதற்கு தொல்லை எதுவும் இல்லை. ஸோ வள்ளுவரை நினைச்சு இன்னும் ஆச்சரியமா இருக்கு. 2000 வருஷத்துக்கு முன்னாலே இதெல்லாம் சொன்னாரா அப்படின்னு. ஸோ இப்போ வள்ளுவர் சொன்னதை இப்போ அவர் சப்போஸ் மயிலாப்பூர்ல இருந்தா அவரோட நெய்பர் இவர், அவர் கூட கேட்க மாட்டார். பிகாஸ் இப்போ மயிலாப்பூர்ல பார்த்தீங்கன்னா அவர் வாழ்ந்த ஏரியாவில் ஃபுல்லாக இப்போ ஃபுட் அவுட்லெட்ஸ் தான் ஆப்வியஸ்லி. ஸோ ஹிஸ் நெய்பர் ஆல்சோ வில் பி taking all this stuff because it's easily available, hyper palatable, and his neighbor will look like this. So this is the scenario. So, and finally, before thanking you, see, this is a cake which is called target practice. This is an actual cake called target practice. Everything is edible here, including that pistol, the bullets, everything is edible. Okay. When you present something in front of someone, இந்த கேக்கை முன்னாடி வச்சுட்டு பார்த்து சாப்பிடுங்க அப்படின்னு சொன்னா இதை பார்த்ததுக்கு அப்புறம் சாப்பிடாம எப்படி இருக்க முடியும்? தட்ஸ் அ ப்ராப்ளம் ஆஃப் டுடே பிகாஸ் வி ஆர் சரௌண்டட் பை delicious inviting food stuff which we are finding it very difficult to resist the temptation to eat. Okay, so the entire presentation is for your thought process, and I hope I have done some justice to the topic taken today, and thanks for patient listening. Thank you.